Welcome to this podcast on aortic dissection. My name is Roy Shepherd, and I've been joined by Martin Hilton and Edward Montgomery, who's also known as Monty. They have personal experience of aortic dissection, and they're going to share those experiences. Hopefully, it will help you if you or a family member is involved. We're going to hear from them shortly, but first I'd like to welcome Mark Field. And Mark is head of aortic surgery at Liverpool Heart and Chest Hospital in Liverpool. Got substantial experience and expertise in dealing with aortic dissection. Mark, welcome. I have been involved in medical conferences for many, many years, and I'm not medical, but when I heard about aortic dissection, I thought, what on earth is that? Can you explain what aortic dissection is, please, in layman's terms?
Certainly. So I guess the first thing to say is extremely rare. And when it happens, it affects all the entire body. So it is, although in simple terms, the aortic dissection is a splitting of the aorta, it has catastrophic effects for the entire body and can be life-threatening. I guess to try and understand some of what I'm saying there, it's important just to understand what the aorta is and what it does. It's essentially just a tube, and it has three layers to it: the inner layer, the middle layer, and the outer layer. That's important to understand. That's about as scientific as I'm going to get. It has a number of branches, so it comes straight out of the heart, and it essentially just channels blood, and it channels a lot of blood, like 5 liters a minute. So it's doing that for over the entire duration of your life. So it's a major conduit, carries a major amount of blood. And the branches, I guess, are an important thing. So it has 2 branches that go to the heart, the coronary arteries, and those are the ones that block off in a heart attack. That's important. And then it goes over a big arch in your chest, and it has branches to your arms and your head, and it goes around the back of your body, down into your belly. There are 4 branches in your belly that go to the kidneys and the bowel and liver, spleen and things like that, and then it goes down to your legs. So that's the sort of basic anatomy of it, and that's important to understand in terms of what effects an aortic dissection has. So the aortic dissection itself is a splitting of those 3 layers, and instead of having one tube where all the blood goes, you end up with a double barrel aorta. So you end up with 2 tubes, and that's because the wall has split. And the effects it has depends on where that split is. So you can have type A aortic dissection, which is a split at the front near the heart. That's a life-threatening condition.
And an emergency.
And an emergency, absolutely. And that requires diagnosis as soon as possible, and we may come to that later on. Diagnosis is a big problem, and that it's often confused with other presenting things like heart attacks and clots on the lungs and things like that. And as I said at the start, it's a very rare thing, so it's often missed as a diagnosis. But once the diagnosis is made, you need to be transferred to a cardiac surgery unit as soon as possible and have an operation whenever you can, whenever the team can be assembled, and whether that's in the middle of the night. Actually, mostly it is in the middle of the night, unfortunately, but that's just the way it happens. Or you can have a type B aortic dissection with a split up the aorta at the back of your body as it goes through your chest and down into your tummy. And that doesn't necessarily need to have an emergency operation. Sometimes that can be just controlling blood pressure, pain, and managing that aspect of the presentation. Sometimes it can be a stent, like a tube that goes up within the aorta. And sometimes it can be an open operation. Rarely is it an open operation in those circumstances. The effects the aortic dissection have is important because the reason why an aortic dissection at the front is a life-threatening emergency condition is because that's where the coronary arteries are, and the aorta traverses the pericardium, which is the sac which the heart sits in. So the complications of an aortic dissection are that it can split off those coronary arteries that go to your heart and could cause you to have a heart attack. It can also cause bleeding in the sac around the heart and squash the heart, and that's another reason for you to be very unwell at the time of presentation. Or if it splits off the arteries that go to your to your brain, then obviously that can present as a stroke. And then as it goes down, as the dissection goes down into your tummy, that can split off those arteries that go to your spinal cord. It can split the arteries that go to the kidneys and the bowel, and obviously that can be life-threatening. So where the dissection occurs is very important in terms of how you're treated, and also the extent of it, because sometimes the dissection can just start at the heart and finish very near the heart. It can be very localized. Sometimes it can split all the way from the heart all the way around the entire aorta and down to your legs. A bit like if you're, not that many people do, but if you're splitting wood, you can get into that plane, and once you get into that plane, it just the blood continues to go down and split the aorta all the way down. Sometimes that can have significant consequences and it'll be life-threatening. Sometimes it's just a condition that's managed medically, and we try to sort of steward the patient into a more chronic state.
You said at the beginning that it's a very rare condition. Who are the people most predisposed towards getting aortic dissection?
So there are probably two groups of people. The main presentation that we see as emergencies, just because of sheer numbers, are patients that have had uncontrolled blood pressure. So they have hypertension. And that's why the government run campaigns and advertisements to try and get you to go to your GP and get your blood pressure checked and get it managed. It's the simplest thing to do to prevent many, many complications of blood pressure, including heart attack, strokes, and at the bottom of that long list is the aortic dissection. But certainly, if anyone's requested to have their blood pressure taken part of a well-man, well-woman clinic, then definitely they should have their blood pressure taken, and it should be managed, because blood pressure is something that doesn't really, or commonly doesn't cause any symptoms, but it's a very significant disease that unless somebody's measured it, you don't know you have it. So a lot of the patients that we see as emergencies are patients that have had undiagnosed, uncontrolled blood pressure. And you can imagine simple mechanics that if your blood pressure is very high, or the pressure in a tube is very high, it will split the aorta. That's a very common thing. There are
male or female, Mark?
So
I mean, we're all guys here, all white guys of an age. Is this representative of aortic dissection?
Yeah, I mean, I guess there is no good evidence that it predominates towards one particular gender. I think it just depends on your ethnic background, on your age, on your geographic location. So I wouldn't say, in my experience, that is particularly biased towards one gender. Although often it is said that women are underdiagnosed in cardiovascular disease generally, in the sense that they either don't present services, or issues like blood pressure may not be considered.
All right. What's the link then between people who lead a sedentary life and people who lead a very active life? And I say this because our two guests today are survivors of aortic dissection, and they're both particularly active.
So, yeah. So one of the other major things that we see in the history of patients that present as an emergency is they've been doing something silly. And when I say something silly, that's probably judgmental, and it's all relative, isn't it? But they've been pushing.
Can we use the word extreme rather than silly?
I quite like silly, actually. You know.
So when I say silly, it's what my perception is: going to a gym and pushing up weights, 100 kilograms or whatever. It seems silly to me.
Well, that is a perfect introduction for Monty, because Monty, where did your aortic dissection take place, and what were you doing at that time?
Well, it happened at the gym. So I laugh now, but yeah, so it happened at the gym, in Monday the 17th of October 2022 in the gym. And I mean, I was in the gym and I was doing a weights program, right? So I got there early for 7 o'clock, no warm up, straight into it, looking to get to my desk at 8 o'clock. And they, and per your description, I thought it was quite well done, Mark, is that, the splitting of the wood. I had a, emergency rupture, and they thought I was having a heart attack. But
so describe the symptoms of exactly what happened to you without going into too much detail, because some people get queasy.
Well, I don't remember anything because it was an emergency. So I've got amnesia. I had about two to 3 days. So I remember the night before. So I'm speaking to you from getting dialogue from what happened. But I know, because I know the gym, and it was on a Monday morning. So, they was there. I'm in a nice gym, and there was actually this physio was there at sort of early doors. He got me, said, called the ambulance, thinking I was having a heart attack. And then I was very lucky to be, as you say, Mark, gotten hold of. And I went to St Thomas's Hospital in London, which is probably one of the best aortic dissection people. And the aortic surgeon was on call, and he heard me coming in, and he said, "Hang on." So he took me in, and they did take a vein out of my leg, thinking that I was having a heart attack, but 24 stitches. But I didn't, and then I was being operated on within sort of 2 hours. So
all right. We'll come back to you in a second, Monty. But Martin, can I ask you, what silly activity were you up to at the time?
At the time the dissection occurred, there was nothing that silly. I was just out for a fairly sedentary run. But the irony of it was, I do remember feeling I was running really well, which I hadn't ran really well for a long time. So it was a bit back to front, really. Before that, I suppose a year or so before that, I had trained hard and completed my first Ironman. So that's probably the silly thing I've done in a sense, but it was very fulfilling and of course very fit. And my cardio fitness rather was incredible, really low heart rate, really low blood pressure and all those sorts of things. So incredibly fit. But maybe had I overtrained, it didn't feel like I did, but who knows? But in the day in question, so a couple of days before lockdown, so classic timing, I was just out running with my wife and just experienced an odd feeling in my chest. It wasn't painful. It just felt like a sudden burst of indigestion is the best I can think about it. And I just kind of wanted to burp. And to this day, I remember thinking to ask my wife, who was there, can you just pat me on the back, like wind me like a baby? And for some reason I didn't. And I was glad I didn't, because obviously I dissected it. It hadn't ruptured, but obviously there's always that risk. And it just a strange sensation which stopped me running, and I walked back pretty much most of the way. And then, we did get picked up by my daughter, taken home. And at that point I was feeling fine, but when I got home and started to sit down, I deteriorated pretty quick then. And
describe deterioration.
Again, no pain at all, no pain, but just felt so tired. And this is what scares me really, because if I'd have been out running by myself that day, I'd have just come home and just thought, I'm just so tired. And I remember sitting on the floor and just starting to doze off. And obviously my wife and my daughter were with me and called the ambulance and bits and pieces. And the whole thing started to set that chain in motion. But I suppose the point I look back on was, gosh, if I'd have been by myself, I'd have probably just taken myself up to bed, and who knows what maybe might or might not have happened from there.
So Mark, what would the symptoms typically be, or have they just described the typical situation?
Yeah, I mean, that's the main symptom is chest pain, and it's chest pain that you
dull, sharp, localized, or
someone's put a knife from front to back, and it's sharp, and it's usually it goes between the shoulder blades from front to back, and it's usually something we often tell patients, patients that we see who are known to have an aneurysm under surveillance in the clinic, that if you get an aortic dissection, it's not a bit of niggling pain that it's not a bit of niggling pain that you just can mistake and musculoskeletal or back pain. It's like somebody's just put a knife through you, and it's really sharp. And but there are patients who it's a bit of indigestion, like Martin's describing, sort of a bit of just feeling a bit unwell. And we do see patients, very few patients though, but who have had an aortic dissection and didn't know, just went to bed, as Martin says, and slept it off, and years later they have a scan for some random reason and they pick up that they've had an aortic dissection. But that is extremely, extremely rare. Mostly if you don't get, as they say, the mortality once you've had your aortic dissection is 1% per hour until you get operated on. For most patients,
for type A.
Most patients, if you don't have your operation soon, you won't survive. But I just wanted to mention something else, because obviously we don't want to discourage people from going to the gym. Obviously exercise is a good thing, and we just need to keep some perspective on it. But it's not just sort of patients who have very high blood pressure or those who are doing things in the gym, but there is another big group of patients that we just need to keep in the back of our minds, those that have existing aneurysms. And so they have swelling of the aorta for whatever reason. It may be because they have a genetic aspect to it, or they have a syndrome. And those patients, the aneurysm is sat there in the middle of their chest doing pretty much nothing until they have a scan and it's an incidental finding, and then those patients are followed up. So you can, if you think about it, a dissection, as I said before, is simply pressure within a tube, and it can be related to that pressure in the tube, but it can also be related to a vulnerability in the wall of the aorta. And that vulnerability is maybe an aneurysm, or it may be the aneurysm that is related to some sort of inherited or genetic component or a syndrome such as Marfan or Ehlers Danlos.
So how can you find out whether you're predisposed to this condition without discovering on the day in the gym?
This is a big problem in terms of screening the population, because screening, it's not an easy thing to screen for. There's no blood test, although we're working on a blood test for it, a similar, like a COVID type lateral flow test for aneurysms. We're working on that at the moment, but mostly it involves a CT scan, which involves a dose of radiation, and it's not easy to put entire populations through a CT scan. At the moment, we're picking up a lot of patients with aneurysms who are having healthy lung screens. So those patients that are higher risk of lung cancer from smoking are having CT scans in these mobile scanners that you see in the supermarket. And those are picking up incidental findings. But mostly, you can have an aneurysm that's sat right in the middle of your chest, and it doesn't cause any problems because it's obviously a big cavity. And it's the first time many people find out about it is when it tears. For those lucky people who may have it diagnosed incidentally because of a scan for something else, they can be followed up and have an elective operation to prevent an aortic dissection.
All right. Monty, you said that you had amnesia for a couple of days.
Yeah.
And perhaps that was the body's way of coping with the trauma. But when your memory came back and you realized what had happened, what are your recollections that you think would be useful for anybody watching or listening to this podcast?
Well, I think it was an emergency, and as Mark said, very lucky to be alive. And, I woke up, totally, I had no idea that I'd had a surgery. So I totally woke up in a hospital with, 24 stitches down my throat. My lung, I had collapsed lung. So I had tubes in my side, tubes in my, four tubes in my stomach, all these tubes, and staring at my wife and her sister and my niece. And that, I just sort of, I suppose the lesson from that is, it took me several days, even a week to understand it. I suppose the lessons is, I talk about, fall in love with reality. Sort of an idea is that, the more I sort of accepted what I went through or understood it more, I think I'd probably put that to people that, whether it's emergency or you're going through it, really just sort of, I think in hindsight, I probably could have embraced or understood what I was in for earlier than what I went through. I came out unlike probably
accept the reality of the situation.
Yeah, I mean, I came out quite a bit angry, actually, sort of frustrated because of this has happened to me, right? I mean, a fit guy, exec, doing all the things, and then totally out of the blue. But I think if I'd accepted that earlier, I probably would have got through the whole situation probably quicker. But it is a difficult experience, and it's a very confronting experience. I mean, I would say there is we'll talk about it, but a big road to recovery, and you can lead a very productive life. But I think for me, facing what I went through earlier would have been probably something I would have enticed people to do.
Martin, what are your recollections and insights that you've gained?
I think some of the insights have been that, I mean, I've gone on since dissection to go on and do some great stuff athletically, back in running and triathlon and things. But I wonder, prior to dissection, did I treat my heart with enough respect? And that sounds crazy, but when you're doing your fitness programs, cycling, running, swimming, all the rest of it, you're very conscious of your hamstrings, your quads, your glutes, and all those things. You stretch them, you're gentle with them. If you get aggravation in them, you rest them. I think some of my training, and not leading up to the dissection, but certainly over the previous 10 years, at times, you're really pushing yourself aerobically to build the aerobic fitness. And I think
so
now,
punishing your body rather than nurturing it.
I wonder, and I wonder with better knowledge, if I had it at the time, if I'd have just been a bit more learned in my approach. And it interests me now.
Kinder to yourself.
Yes, but it interests.
Warmed up. I mean, a big thing for me is actually the warm up. Like, I did no warm up. I was in the gym. I mean, I have a bit of a genetic thing, but I just get in there, weights, no warm up. I mean, I know it sounds stupid, but I didn't even do that.
I agree, and I think monitoring, and it interests me now that in the last couple of years, you see football players. They're all monitored now, when they're playing and training, and other athletes, they're monitored, they're being measured throughout the activity. And I think, if I had my time again, I'd be monitoring my blood pressure more frequently than I did. And that's something I do very regularly now. So that's probably my biggest learning, is to sort of, look after the heart as I looked after my other muscles.
Well, as Mark said at the very beginning, it is literally at the heart of everything. Mark, you've talked about diagnosis, and it seems to me as an outsider that it's rather hit and miss, unfortunately, still. But once people have been diagnosed correctly and accurately, what are the usual treatment regimes?
So, in an emergency situation, once you've got the diagnosis, and the diagnosis could be made in many different healthcare settings. So you're not necessarily in a cardiac surgery center. The doctors in A&E, where most of the diagnoses are made, because patients present with chest pain, and the differential diagnosis, as they say, what are the possible diagnoses that a doctor may think about when someone presents with chest pain, is usually a heart attack, and the majority of them, by far the majority of the lethal ones will be a heart attack, but also a lot of patients just present with musculoskeletal pain from exercise and things like that. And down at the bottom, again, is aortic dissection, and the doctor needs to think about it and consider it, and the charity are being quite instrumental in trying to get doctors to think about aortic dissection in A&E. And then once the diagnosis is made, which is usually on a CT scan, then it's really about getting to a cardiac surgeon. And not just any cardiac surgeon, you want a cardiac surgeon that specializes in doing aortas, and a surgeon that does aortic operations every week of the year electively and has a vast experience, and can apply that experience to the emergency situation where the surgery is extreme and the patients are at their worst, they're most unwell. And it's not just the surgeon. Obviously, you want the entire team around you, that the anaesthetist, the scrub nurses, the perfusionists who manage the bypass machine, that team. You want them to be doing the work as the day-to-day sort of bread and butter things, and then they apply all that in the emergency situation. And the charity, as again, Graham and Catherine have been instrumental in trying to reorganize this services nationally. It used to be that every cardiac surgeon in the country could do an aortic dissection if they were just on the rota. Now there's definitely a move towards subspecialized rotas, so that there are teams of aortic specialists who do these operations. And it may be that not every center does them, and it may be that you need to be transported in an ambulance to somewhere where you can get the best care. And sometimes the ambulance may drive by a hospital that does cardiac surgery to get to a hospital that has much more experience, and your chances of survival are much better. So for type A dissection, the treatment is an operation. It's a cut through the breastbone. It's onto the heart-lung machine. It's cooling your body down from 37 to 20 odd degrees centigrade. It's a sort of 8-hour operation. It's the far extremes of what is possible. And it's incredible what the body will tolerate in terms of these type of operations. For a very few patients who are elderly, who have multiple comorbidities and who are suitable, it may be that even if you have a type A dissection, you're best managed medically. And by that, I mean blood pressure control and just steward that patient into a chronic state, simply because the operation is so extreme that in some patients, it's just not possible to do it. But those are the minority, I should say.
It seems to me that the lack of knowledge from the patient is one thing, but the lack of knowledge from the medical practitioners is also something that, as you say, the charity has been working on to raise profile, to become far more attuned to what it is. I remember the first time I came across it, I interviewed Bob Harris, the BBC broadcaster, and he, survived an aortic dissection. And he just said how lucky he was because his doctor knew about it. So is it really as simple as that? If you've got somebody that actually, that's aortic.
Yeah, so hopefully you have systems in place that negate the need for someone to think about it, as it were. But unfortunately, quite often it is that, because you may face a junior doctor in A&E, who's been working for a couple of years, and he may in the 6 months he's in A&E, or he or she is in A&E, they may never see an aortic dissection. And certainly when I worked in A&E for a year, I never saw an aortic dissection. So I saw lots of heart attacks, lots of clots on the lung, lots of other things, and so. It can, because that doctor also is able to discharge you. Okay, you've got musculoskeletal pain, it's fine, we'll discharge you. And Catherine's story, as we all know, is very like that, presenting to A&E, meeting certain people with certain experiences, and then being discharged and then coming back. And so that it is.
This wasn't, for the benefit of people that don't know Catherine's story, yes. It's not her story as such. Can you very briefly say the story?
So it's just her father, which had a type A dissection and was basically sent away from A&E, and then represented later on. And then by the time the diagnosis was made, it was unfortunately too late for her father. But obviously, she had another relative who had a dissection roughly at the same time, who had very different care and was diagnosed and had treatment and was very successful. And that's a dichotomy there. But what the Aortic Dissection Toolkit tries to do is tries to make the whole process more systematic, so that it's not dependent on individuals thinking about it, that you have processes in place that when you come in, you've got chest pain, you go through a screening tool. This is what we consider this diagnosis, and you have a CT scan. And so no system is going to be perfect when the condition is so rare, but certainly the Aortic Dissection Toolkit, which is unique across the world, really, it's certainly an achievement for the UK, to organise national services into networks and raise awareness around the diagnosis, raise awareness around the treatments, and to get the best treatment that people can. And so it's hopefully, well, it definitely is better than it used to be. In all aspects of the service, it's much better than it used to be.
Can I jump in there, Roy? Because I think, interestingly, with my diagnosis, I think after a certain time I'd got stabilized. There was lots of scans and bits and pieces like that whilst they were determining what had happened. But once I'd sort of stabilized in hospital, I'd obviously gone to A&E. If they'd have said, okay, everything seems okay, would you like to go home? I would have jumped at it because I felt fine. And that it must be so hard for the medical teams. I always think this, I'm not medical myself, but if someone presented with their leg hanging off or something as crass as that, you know there's a problem. But for me, if they'd have said, yeah, you seem okay, you stabilized, not quite sure what's gone on, go home, rest up, and if something happens, come back, I'd have happily grabbed that. And that's the, I suppose, one of the difficulties of it, Mark.
Well, obviously, Monty, you were not aware of what was happening. So the system was working on you and literally saved your life.
Yeah. I mean, I think I was very lucky. I think I probably, St Thomas's Hospital in London is probably well renowned for aortic dissections in terms of the medical person there. So he was on call, and he heard me come in and said, hang on, this may be one for me to do versus a heart attack. So that was, I was extremely lucky. And obviously I was acutely in danger of losing my life. And, I got saved, basically, as Mark said, 6, 7 hours.
Yeah, by people like Mark. So, Mark, what advice would you give to people who may be experiencing symptoms that may or may not be aortic dissection, and perhaps any insights for family members? I mean, Martin was lucky he had his wife with him at the time. So what would you say in bringing this first podcast to a close?
I think advocacy, like Martin was saying, I think, taking responsibility for your health is important, and accepting there are deficiencies because it's such a rare condition. It's, rare as hen's teeth. Accepting that there are difficulties in the diagnosis. I think it's important that the general public take responsibility for their health, obviously. But when you present to A&E to advocate on your behalf, really, and relatives as well, and I guess it's probably not realistic, to say, to go into A&E with the chest pains and say, well, are you sure you want to send me home? Do I have an aortic dissection? But I think it is perfectly fine to advocate on your behalf or on behalf of a family member to ask a few questions.
So what sort of questions would you recommend they ask?
So I would ask about, and it's a little bit difficult because obviously I'm a doctor and I know what questions to ask, and I have the words to ask those questions, but just to ask some simple questions about what they think the diagnosis is and why they think it's like that. So just not to tell them what to do, but just to trigger the thought in their mind, like, why am I getting this pain? And will it go away? And what should I do if it doesn't go away? And so simple things like that. I think those are the simple questions that a member of the lay public could do. Just be inquisitive. Don't just be accepting of the diagnosis and say, yeah, okay, fine. I mean, obviously, I understand Martin's point of view. He's desperate to be told that he is fine, and so patients will be happy to go home because that means that they're but ask a few questions, be inquisitive, just generally, just don't be accepting of what all doctors tell you. It will be my advice, and my medical colleagues may lynch me for that. But
well, I was just thinking that is not the soundbite to take from this podcast. I know.
I'm glad Mark said that and not Monty. All right.
Any final comment that you want to make, Monty?
Any final comment? I mean, on that, I mean, one might say things is be a master of your own health. I think that's probably poignant for me because I've had a few complications outside the aortic dissection. So I think the more, I say also, don't make this your story, but, you be the master of your own health and be curious and on top of it and ask the questions for the doctor. They'll give you their advice, but I think intuitively you may know, and I think the more you know, the better off you'll be. So that's probably one point I'd make on that.
All right, Martin, final comments.
I think what it taught me and what I'd pass on is the understanding that life is or can be so very fragile, and that was quite a learning for me. And I've not turned into a crazy hypochondriac, and I wouldn't suggest that, but just, I suppose we expect to live to a certain age, into our 80s or whatever the average age is, and all the rest of it, and we go through life. But actually, things can happen, and I think being aware of that, and then, getting the right diagnosis, helping facilitate that, as Mark says, is worth thinking of.
Yeah. Be active, but not silly, I believe, is the word of the podcast.
Absolutely.
Can I just say thank you to all of you for joining us for this podcast. I really hope that you've all found it useful to listen to and to watch. Mark, a massive thank you for your time. Really appreciate your time. Thank you so much.
Yeah, thank you, Mark.
Thanks, Mark.
So that's the end of the first episode in this short series. The second episode is going to be about the key stages in the recovery process of aortic dissection. So I hope you can join us for that. Once again, all of you, thank you so much for joining us.
Thank you.
Thank you.